and delegates. Myself Dr. Darshan Rathi. I am MCCology resident from Grand Government Medical College at JJ Hospital. My topic is incidence and evaluation of etiology of bladder outlet obstruction in a female patients, a prospective observational study. The points we will discuss today is definition, symptoms, incidence, negative effect, evaluation, management, and discussion. By definition, given by International Medical Society as a generic term for obstruction during voiding with a reduced fluid flow and or presence of rest postmortem residual and increased red pressures. There is a complex symptomatology in a female and classic voiding symptoms as seen in male are not seen in a female, leading to late reporting. Though the incidence of POO is not high, but it leads to bothersome urinary tract effect symptoms, and therefore there is a negative effect on overall well-being. The aim of the study is to determine the incidence and etiology of bladder outlet obstruction in female patients. The methods are: we did the prospective observational hospital-based study for a period of 1 year 6 months. We do detailed clinical history, physical examination, urine analysis, uroflowmetry, ultrasonography as a routine, urodynamic procedure in a patient with a flow rate less than 12 ml per second and or significant postward residual volume. Inclusion criteria were age group less than 18 years and above, female patient with a bladder outlet obstruction, female patients who underwent urodynamic study for LUTS and show signs of bladder outlet obstruction. Urodynamic criteria for BOO is Qmax less than 12 ml per second with a pediatric Qmax greater than 20 cm of water. Exclusion criteria are urogenital malignancy, proved neurological illness, symptomatic UTI, bladder calculus, history of spine surgery or no spine pathology. Core urinary tract symptomatic score questionnaire was given to fill by the patients at initial encounter and followed after 2 weeks, 1 month and 3 months. Obstetric menstrual drug history was taken. We did the management depending upon the underlying cause and asked the patient to follow up for a period range from 1 month to 3 months. Symptomatic improvement, physical examination and ultrasound were the main diagnostic tool for follow-up. Here the results of my study are: the mean age of study participants was 52.9 plus minus 16.5 years. Highest percentage of participants were in the range of 51 to 60 years and the least percentage of participants were less than 30 years of age. Out of 54 women, 19 were premenopausal and 35 were postmenopausal. About parity, there are 33.3% has true parity and 3.7% has no parity. Out of 54 women, 31 patients, that is 57.4% patients has anatomical cause of BO and 23 patients, that is 42.6% patients functional cause of BO. The main cause for anatomical obstruction was urethral stricture as seen in 13 patients. Rest of the causes are cystocele, meatal stenosis, atrophic urethritis, bladder neck stenosis, urethral caracal, cystocele, senile urethritis. The main cause for functional obstruction was dysfunctional voiding as seen in 20 patients. Women with a functional BO has significantly lesser age as compared to the women with an anatomical BO. The most common clinical symptoms were daytime frequency, nocturia, urgency, slow stream, straining, incomplete emptying, intermittency, and resistance. Significantly higher percentage of patients with the anatomical BO has a slow stream as compared to the patient with a functional BO. From 54 patients, 27 underwent pelvic floor muscle training, 51 were on medical treatment like alpha blocker, 13 were on other medical treatments, and 27 underwent surgery. For a discussion, bladder outlet obstruction in a female has a prevalence rate from 2.7 to 23%. The cause of obstruction can be anatomical or functional. Treatment is guided as per the anatomical cause, and treatment options range from medical to appropriate surgical interventions. In our study, the mean age is 52.9 plus minus 16.5 years. Similar study done by the Sachin Male et al. In 2019, having the mean age is around 51 plus minus 15 years. And the study done by the Blaves et al. Having the postmenopausal percentage is around 76%. In our study, the rate of postmenopausal female is 64.8%, whereas the mean parity is around 2. And study done by the Blaves et al. Having the mean parity is around 1.8 plus minus 1.3. In our study, out of 54 patients, 31 patients has anatomical BO and 23 patients having the functional cause of BO. Similar study done by the Blooper et al. In 2023 conducted 157 female patients. Out of that, 54.5% patients having anatomical and 45.2% patients having functional cause of bladder outlet obstruction. In our study, the patient with a functional group of bladder outlet obstruction has a significantly lesser age as compared to the anatomical cause of BO. A similar study done by the Grouper et al. Having lesser age in the functional group as compared to the anatomical group. The clinical symptoms in our study and the study done by the Robert et al. Having almost similar, that is frequency, urgency, nocturia, hesitancy and strength. The prevalence of the storage and voiding nerves in our study was in line with the prevalence of literature. Regarding the prevalence of storage symptoms, there is no difference in anatomical and functional because of behavior. But regarding the prevalence of the voiding symptoms, there is a higher trend in the anatomical group. Similarly, similar reports are found in the study done by the Grouper et al. Having the higher prevalence of the voiding symptoms in anatomical behavior. In our study, out of 54 patients, 21% patients having the urethral strictures. Similarly, the study done by the Grouper et al. Having urethral stricture rate is 16.6%, and the study done by Sachin Mande et al. Having urethral stricture rate is around 20%. Rest of this causes cystoscopy, anti-incontinence surgery. In our study, the functional group, 20 patients, that is 37% patients have the dysfunctional voiding. Similar reports like Grouper et al. Having the dysfunctional voiding rate is around 21.7%. In literature, the incidence of dysfunctional voiding range from 10.5 to 36.3%. 50% of patients underwent surgical treatment and rest were managed by medical therapy and of physiotherapy. In the non-surgical group, that is 27 patients, after a follow-up of 3 months, there is a significant decrease in the lower symptomatic score and quality of life symptomatic score. PVR decreased significantly with the average decrease in around 48.4 plus minus 42.3, and Qmax improved on an average around 8.3 plus minus 3.8. In the surgical group, after a follow-up of 3 months, there is a significant decrease in the CLSS and the QOL score. PVR decreases from baseline 90 to 22 with the average decrease in around 68.3 plus minus 65.9, and there is a overall average improvement in the Qmax around 9.7 plus minus 2. So for a conclusion, bladder artery obstruction in the female can either be anatomical cause or functional cause. In our study, a relatively higher percentage of patients diagnosed with a dysfunctional voiding and take to present at a younger age. Urodynamics should be done in a patient to rule out functional cause in absence of any obvious anatomical cause of obstruction. Treatment directed at the cause of obstruction show better outcome, with medical therapy, mainly alpha blocker, being main treatment modality of functional causes, and surgical therapy anatomical causes of obstruction.
Thank you for the very good presentation. But my question is, how did you differentiate between anatomical and functional obstruction? Because nowhere in your inclusion criteria, cystoscopy or difficult catheterization was